Management of rectal cancer. Most important presentation of rectal cancer is fresh bleeding per rectum. There can be mucoid discharge from tumor, leading to whitish mucoid diarrhea with or without blood. Advanced rectal cancer may narrow the lumen, leading to constipation and then obstruction. There can be perforation of tumor of upper rectum in peritoneal cavity, or there may be perforation of dilated proximal colon in case of obstruction. Tumor may grow up to pelvic wall, leading to involvement of pelvic nerves and pain. Tumor may involve pelvic floor and external sphincter complex, leading to incontinence. In severe cases, there can be rectovaginal fistula due to involvement of vaginal wall. It is important to examine rectum by finger, and examine whole body for any signs of metastasis. When doing perectal examination, it is important to note distance of tumor from anal virgin pelvic floor. Look for dimension adequacy of lumen, dimension of tumor, and mobility of tumor. TNM staging is used in colorectum. There are 3 layers in mucosa: epithelium with basement membrane, lamina propria, muscularis mucosa beneath mucosa, submucosa. In general, cancer cell limited to epithelium without breach of basement membrane is not considered neoplasia, but is called in situ or intraepithelial neoplasia. Malignancy is defined by breakage of basement membrane and spread of cancer cells into lamina propria. In all gastrointestinal invasive cancers, except colorectal, invasion of lamina propria is considered malignancy. But in colorectal cancer, this is an important difference from rest of GI cancers. In colorectum, invasion of lamina propria without penetration through muscularis mucosa is termed TIS, as it is associated with negligible chance of mets. It is also called intramucosal carcinoma. Tumor grows into submucosa, and this is T1 stage. Involvement of muscularis plane is T2. Involvement of mesorectal fat without penetration of mesorectal fascia is T3. T4 is penetration of mesorectal fascia and or involvement of adjacent organs. Most important investigations in rectal cancer are colonoscopy, biopsy, pelvic MRI, 40 and end staging, contrast CT scan abdomen and thorax, 4M staging, serum carcinoembryonic antigen CEA. Biopsy can be done by proctoscopic guided or colonoscopic guided. Colonoscopy can diagnose any polyp proximal to mass. Things to look for in pelvic MRI are distance from anal virgin pelvic floor, depth of tumor, whether tumor has penetrated through muscle into mesorectal fat or is intramural. Circumferential resection margin. It is distance of tumor from mesorectal fascia. Any lymph nodes in mesorectum. Pelvic group along iliac vessels or higher up. Extramural venous invasion EMVI. It is presence of tumor in small veins. It has been seen that EMVI increases risk of liver metastasis. Full colonoscopy is required because in cases of colorectal cancer there are chances of synchronous cancer or adenomatous polyps elsewhere in colon. Circumferential resection margin. CRM is an important variable when determining resectability and need for neoadjuvant treatment. Initially, tumor is limited to muscles, but it grows into the mesorectum and also gives nodes in mesorectum. CRM refers to distance between lateralmost margin of tumor and mesorectal fascia. It is calculated in millimeter. CRM is said to be positive if distance is less than 1 millimeter. Nodes involving fascia is also taken as positive CRM. If CRM is positive, then while doing total mesorectal excision, chances of leaving microscopic disease and surrounding increases, which increases chances of recurrence. Hence, in such cases there is role of neoadjuvant radiation, which causes shrinkage of tumor and moves tumor away from mesorectal fascia and also regresses nodes in mesorectum. Thus it decreases risk of recurrence. This dictum of primary surgery or surgery after neoadjuvant is applicable in upper and middle rectum. In lower rectum, other issues are also important in deciding neoadjuvant treatment, like sphincter preservation. This is discussed later in this video. In management of upper rectal cancer, in early stage such as T1, T2, N0, surgery is primary treatment. There are two types of distal margin. One is where bowel is transected, another, where mesorectal is cut. These margins are measured in centimeters from tumor edge. For well-differentiated tumor of rectum, distal mucosal margin is around 1 to 2 centimeters and distal mesorectum margin is 5 centimeters. In poorly differentiated tumors, 5 centimeters is acceptable for both bowel and mesorectum. In advanced tumors like T3, T4 and nodes positive, neoadjuvant radiotherapy is given before surgery. Since total mesorectum is not removed, only 5 centimeters distal to tumor is removed, so it is called partial mesorectal excision. If anastomosis is above peritoneal reflection, then it is called anterior resection. Rectal excision below peritoneal reflection is called low anterior resection. In case of middle rectal cancer, in early stages low anterior resection is done. In advanced non-metastatic, T3 or T4 or node-positive disease, neoadjuvant radiotherapy is given followed by LAR. Total mesorectal excision is inherent part of low anterior resection for middle and lower rectal cancer. Bowel is transected at 1-2 cm distal margin with complete mesorectal removal. For poorly differentiated tumor, 5 cm mucosal margin is usually acceptable. For low rectal cancer, in early disease, if 1 to 2 cm margin can be achieved with space for firing stapler or suturing above pelvic floor, then resection is done with TME if less than 1 cm margin is present distal to tumor and pelvic floor. Then there is option of giving neoadjuvant radiotherapy. With radiation, there will be shrinkage of tumor and margin may then be achievable. If rectal cancer is involving external sphincter, then abdominoperineal resection is done, which means removal of rectum and anal canal with permanent colostomy. APR is of two types, standard and extralevator. In standard APR, while doing mesorectal excision, as we follow curve of mesorectum, there is tendency to come close to tumor due to coning near pelvic floor, as mesorectal thickness narrows, thereby increasing chances of recurrence. This is called narrowing of waist. In extralevator APR, wide margin is taken by coming vertically down and cutting pelvic floor away from tumor. This is also called ellip. In case CRM is close or positive or there are mesorectal nodes, then neoadjuvant radiation is given before surgery. In cases where distal margin is less than 1 cm and disease is intramural, early, then there is another way of achieving more distal margin, that is intersphincteric dissection. While doing TME, once pelvic floor is reached, intersphincteric plane is entered and internal sphincter is removed as extra margin. As we know, internal sphincter is continuation of circular muscle layer of rectum. Hence this is appropriate for cancer localized to muscular layer of rectum and not involving intersphincteric space. Intersphincteric dissection can be total or partial as required. If intersphincteric space is involved or external sphincter is involved, then standard treatment is APR. After rectal surgery, especially more than T2 and node-positive disease, there are chances of deposits in pelvis and chances of distant metastasis, especially to liver and lung. However, in disseminated cancer cells, we hope chemo will kill 100% of cancer cells. But in reality, this may not be possible. Residual cancer cells then regrow to give recurrence and further dissemination. Similarly, radiation may not be able to kill 100% of cancer cell deposits in pelvis, leading to pelvic recurrence.